Hi everyone, this is Dr. Heather Austin Robillard, and in this module lecture video, I will be introducing you to the assessment process for substance abuse. This lecture will cover what actually assessment is, what is the process of conducting an assessment, and what is needed in order to conduct a quality assessment. You will also learn a little bit more about the elements of the biopsychosocial interview, or the BPS interview, and the ASAM patient placement criteria. The two of these are very commonly used methods in the treatment of addictive disorders. So many of you might think that assessment is just gathering information, but it's actually much more than that. Oftentimes, the way that we discuss assessment, it sounds as though it is something separate from actual treatment, something that might happen before treatment begins. But in all actuality, gathering the information is treatment. The process of gathering information helps the client or the patient begin to reflect on their experiences of the problem. When conducting assessments, it's important to conduct both an individual assessment with the client as well as family members when possible. Oftentimes, when working with addictive disorders, family members might be able to relay information that the client may not recall or may not consider important, or in the same lens that their loved one might. It's not always possible to have family members a part of the assessment process, but it's important for the treatment provider to at least make an effort to invite them and include them in that assessment process. Finally, and with equal importance, when assessment is done correctly, they can ensure that the client is accurately diagnosed and allow for a comprehensive treatment plan to be created. Addiction issues are extremely underreported, and if the professional does not ask them or does a poor job of actually assessing for the different behaviors and uses, then the client may not be able to move forward with treatment, which could be a major issue if it's ignored. So what does the assessment process look like? This diagram shows you the process of assessment, starting at the top with the initial screening, moving all the way down to the creation of the treatment plan. You'll notice that the first deviation from the typical plan is crisis intervention. If a client or a patient comes in for help and they are in a crisis situation, such as reporting that they're suicidal or homicidal, or that they have some hallucinations or psychosis, then crisis care comes first. These concerns need to be addressed properly in order to conduct any further assessments. It makes it difficult if they are suicidal or in psychosis to continue the accuracy of their assessment plan. Once the crisis is over, or if there's no crisis at all, then you move on to the actual assessment plan. This includes looking into the past assessment information. So this might be if the individual has been to treatment before, and asking information from the client or their family, school, or medical providers. This helps to gather a very well-rounded view of the problem from multiple parties, as well as includes information from their past treatment. Once all of this information is gathered, and hopefully from multiple people, self-report, interview assessments, measures, etc., the current findings are then reviewed and both a summary report is given as well as an initial diagnosis should be made. The summary plan and the diagnosis help create a treatment plan, something you'll learn more about later this semester. So what is needed to create a successful assessment? For the assessment to be considered successful, the treatment professional should use multiple methods to collect data, as well as receive information from multiple sources, such as family, past therapists, anything like that. Multiple sources should be gathered through multiple types of assessment. This typically starts with initial screening tests. There are many short, quick 5 to 6 question type questionnaires that can be used to assess problematic use and the severity of their addiction, which will tell the professional whether or not a more intensive measure or tool is needed. Let's use alcohol as an example. There are multiple screening instruments that are very quick to use and easy to remember to ask about problematic use, including the cage, tweak, or the audit, and there's many more of these. Each use these acronyms for the actual measures questions. The CAGE is probably one of the most popular ones. The CAGE is probably one of the most popular ones. The CAGE has been adapted for alcohol use as well as other addictive substances and behaviors. The CAGE stands for the following questions. Have you ever felt like you should cut down on your drinking? Have people ever annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And the last one is more of like an eye-opener question. Have you ever had to drink first thing in the morning to steady your nerves or to get rid of a hangover? The words cut, annoyed, guilty, and eye-opener, these are 4 words that are key to remembering the questions to the CAGE. The client answers yes or no to each of these questions. And really, a yes to any of these questions warrants further assessment for alcohol or other addictive substance use. The other quick tools are similar to this and tell the professional which direction to go. After the initial screening has taken place, the professional should move forward using validated assessment measures that are more detailed and provide more information that looks reliable to the client's problems. Paper and pencil assessment measures offer several key benefits to the process. One, they are usually inexpensive or free, and most importantly, many clients will view these as being less threatening than a face-to-face discussion about the problem. This might cut out the concern that the professional is negatively viewing them or removes any intense feelings of shame, guilt, distrust, or hopelessness. One of the disadvantages to this is that clients can lie, manipulate the screening measures. One of the disadvantages to this is that individuals can often lie or manipulate these screening measures. Again, there are many options here, and we'll go back to the example of alcohol as the problematic cause to discuss examples. The problem assessment stage assessment measure looks at the symptoms based on the DSM criteria. Measures the severity of alcohol dependency, measures the dependency issues. The Substance Abuse Subtle Screening Inventory, or the SASI for short, is a very commonly used self-assessment measure that is easily administered and scored. It has about 93 items for adults and 100 for adolescents. It takes a client or patient around 15 minutes to complete, and it can be done with paper and pencil or on a computer. After the initial screening and use of assessment measures, the next stage of assessment is more often the interview format. A popular interview procedure is the BPS interview, or the Biopsychosocial interview. We'll discuss this more later in this video lecture. Additionally, the interview should discuss such topics as readiness for change, which is helpful to use the stages of change model. Other topics should include antecedents for addictive disorders, self-efficacy, coping skill. Does the client use any other coping technique to deal with their stress? Spirituality or religious affiliation, cravings, any affiliations with the 12-step program, other comorbid concerns like mental health issues, neuropsychological deficits, and the use of the patient placement criteria from ASAM, which we will also discuss in this lecture. While the professional is conducting the assessments, it is critical for the professional to consider their role in the process. First, it is important to remember no single test will be 100% accurate, and that is why it is important to get data from multiple sources. A person may report that they're abstaining from a chemical substance, but their urinalysis may reveal that they're actively using. A patient may say that their substance use has not caused any problems in their life, but a spouse may say that they've been financially burdened by their addiction. It is also important to keep the stages of change in mind and to consider how effective each individual assessment measure is for the client being evaluated. Finally, the assessment process and the results should be transparent to the client or patient. Be open with the client when possible about why a specific test is being used. This slide is just a quick review to refresh your memory about the stages of change learned about earlier this semester. Remember that stages of change start with pre-contemplation, where the client is in denial and needing help and does not currently have plans to change. Moving all the way to the end of the model, where the individual goes from maintenance of active sobriety for up to 3 years to being in recovery and leaving the cycle, or having to relapse and starting the cycle from the very beginning. This information was presented in the first module. Before diving into the BPS interview, there is another important piece to point out. With the assessment stage, professionals will use different formats of face-to-face assessments depending on their employment site's preference. In general, assessment interviews should focus on mental status exam, presenting issues, or what brought the client into treatment. Substance use or process addiction information, including the amount, frequency, both the current and the history of these uses. The method of use, pattern of use, the context of their use, whether they were using it with family, friends, or by themselves, tolerance and dependency, and then withdrawal symptoms. Also, you'll want to be sure to assess for any prior treatment experiences, consequences of their use, whether that's socially in their family, school, military, medical, legal, financial, psychological, and even problems in their spiritual or religion. The BPS interview gets at many of these above for its key elements, which is why it is a popular method of gathering information. The BPS does not have a particular format, but it does contain the following components. Information about the client's past history. This is just general personal information. Should be the first step in the BPS interview, as it helps develop a relationship with the client and can help start them off on an easier topic to warm up to the more difficult areas that are needed to discuss. This section will ask about place of birth, date of birth, developmental milestones, who they were raised by, ethnicity or cultural influences, home of origin, college or military history, occupational history, employment satisfaction, and financial history. These will also inquire about sexual orientation, relationship history, social support, spiritual orientation, strengths, personal preferences, hobbies, and leisure activities. Finally, this section of the interview will move into issues concerning abuse, physical, emotional, or sexual concerns, gambling, their current sexual history, perceived areas of growth and weakness. Gathering information about the individual's history of use, the professional will inquire about the age of onset of their first use of substances, behavioral addictions, the duration of their use, pattern of use, such as specific triggers or life events, consequences of their use and previous treatment, blackouts, tolerance, and withdrawal. Next, gathering information about the individual's mental health history. Specific information on diagnoses related to depression, anxiety, eating disorders, or manic episodes. Then you'll want to discuss the individual's medical history, specific information on illnesses such as hospitalizations, allergies, medications the client is currently taking. Then you'll want to understand the individual's family history. Similar as above, illnesses, history, mental status, substance or behavioral addictions in their family, relationships with family members. The last one is observations made by the professional during the interview, specifically about their mental status. Just giving a description of the client on what they are wearing, how they were during the interview, alert, oriented to the interview, drifting off, speech patterns, low affect, any red flag issues related to safety, like suicidal ideation or homicidal ideation, delusions, obsessions, memory loss, impulse control, and motivation for treatment. This diagram is depicting the 6 dimensions from the American Society of Addiction Medicine criteria for placement. It has 6 recommended dimensions that you inquire about to decide how a client or patient should be placed in treatment. The ASAM criteria is the most widely used criteria for assessment, placement, continued stay, and discharge planning for addictive disorders. As outlined in your textbook, each dimension will have specific focused questions to inquire about with your client for the purpose of determining what is the best level of care needed for them to treat their addictive disorder. Since your text covered most of it, we're not going to go too much in depth about it, but I did want to just kind of highlight these different dimensions. Each dimension is given a rating to express the severity of care needed for each dimension. Patients can move up and down the continuum and reach new levels of care depending on where they are at in their recovery or their treatment. When considering where to place an individual, we want to think of the 3 H's. That's history, the here and now, and how concerned you are with their safety. For each dimension on the ASAM placement criteria, we want to ask about their strengths, their support systems, their resources, their risks and deficits. This is important to consider when deciding the level of care needed for treatment. Professionals should also consider imminent danger. Is the client in danger for any of these levels? Before we go into the specific levels of care, we can think about the outpatient versus inpatient care. We can think about the outpatient versus inpatient criteria. Outpatient is a good option when the client is not acutely intoxicated, they have minimal withdrawal risks, they are medically stable, they're not at risk for harming themselves, their mental status does not prohibit participation, and they are receiving care for any mood disorders they may have. The client is also expressing willingness to cooperate with treatment. They need monitoring but do not require higher level of structure of monitoring. They are able to remain abstinent only with support measured between sessions. And they have an environment that is supportive of the client, willing to create an environment conducive to recovery. Inpatient is a good option when the inpatient is optimal. Inpatient is a good option when there are severe risks of withdrawal, past failures after detox, they are in imminent danger to health if use resumes, or there's other medical conditions that require monitoring. When there's emotional or behavioral problems that require a 24-hour watch, when they are at risk for harming themselves or others and they have impaired daily functioning or a history of violent behavior. Also, if they, despite consequences, they do not accept the severity of their use and they need an increased level of care, cannot control the use in their outside environment. Another reason would be that they live in an environment where treatment success is unlikely. The accessibility prohibits lower levels of care, dangers of abuse or risk of safety in their current environment are impaired. Level 0.05 is at early intervention. Individuals are at a high risk of developing substance use disorder. Treatment should have ability to recognize and provide referrals to more appropriate levels of care if individual is a danger to themselves. Examples of this might be DUI education, basic education, early intervention with adolescents. Outpatient is level 1. Less than 9 hours of service per week are needed. Recovery and motivational enhancement strategies can be used to help this individual succeed with goals. Appropriate for individuals with a low severity in all dimensions of assessment. Dual diagnosis capable or dual diagnosis enhanced. Level 2 is intensive outpatient or partial hospitalization. IOP is more than 9 hours a week and PHP is more than 20 hours. This stage is for clients who need 24 hours of care, not able to be on their own. Patients are provided treatment during the day, after work or school, in the evenings or on weekends. Treatment options have the capacity to provide medical and psychiatric consultation, psychopharmacological consultations, medication management, and crisis services. Level 3 would be residential or inpatient treatment. For those clients that need 24 hours of treatment services in a safe environment, this level of placement is its own intensity rating from level 3.1, which is clinically managed low intensity, to level 3.7, which is medically monitored inpatient. Level 4 is medically managed inpatient treatment. 24 hours of medical and nursing care with staff credentialed in mental health and addiction. This has the capability of an acute care hospital or psychiatric hospital for severe unstable problems in dimension 1, 2, and 3. Must be a dual diagnosis client. Now we will look at the diagnoses for substance abuse disorders, Substance use disorders in the Diagnostic Statistical Manual, or the DSM-5, was created by the American Psychiatric Association. Every few years they do have an update, and the most recent edition is the DSM-5. Some of the important changes made to the DSM were towards the addictive disorders. As we've mentioned before, it used to be talked about as substance abuse or substance dependence, and now it's just substance use disorders. This diagnosis is measured on a continuum from mild to severe based on the number of criteria an individual meets. Mild substance use disorder is when a person meets at least 2 to 3 of the diagnostic criteria. Moderate is when they meet 4 to 5 of the diagnostic criteria, and severe would be if they meet 6 or more of the 11 criteria. And the criteria are as follows: taking a substance in larger amounts or for a longer amount of time than meant, wanting to cut down or stop using the substance but not being able to, spending a lot of time getting, using, or recovering from the use of substances, cravings and urges to use that substance, not managing to do what you should, like obligations of work, home, and school because of your substance use, continuing to use even when it causes problems in your relationships, giving up important social, occupational, or recreational activities because of the substance use, using substances again and again even when it puts you in danger, like driving a car, continuing to use even when you know you have a physical or psychological problem that could have caused or made worse by the substances. So using medication while also drinking or something like that. Needing more of the substance to get the effect you want, which is tolerance. A development of withdrawal symptoms, which can be relieved by taking more of the substances. Addictive disorders also now include a process addiction, which is gambling, the gambling disorder. This was previously categorized in the DSM as a pathological gambling, but in a different chapter, not under addictions. And now it's actually in the addictive disorders as gambling addiction. So there you have it. This lecture discussed the assessment and diagnosis of addictive disorders. It's important for professionals to understand how to assess their clients for their substance use disorders and gather the best information to make the treatment plan that is foolproof for this client. This information will be helpful for you as you create your assessment plan for your client, as well as the treatment plan that we will discuss later on this semester.